The first speaker is Dr. Mehul Shah, who will be talking about intravitreal injections of antimicrobials.
Good morning to all, and thank you Dr. Rajeshina and Dr. Titiyal sir for allowing me to be here under their privileged leadership. So we will think about injection first with this study. This is the benchmark study, endophthalmitis vitrectomy study, which has stated some important, it has made certain important statement that all endophthalmitis may not need surgery. Anywhere vision above hand movement can be treated and should be treated primarily with antimicrobial injection. That's what is base of our this condition. And these are the microbial doses that is all available and everybody knows. So these are the conclusion of EVS. Intravenous antibiotic used at the time show has got no additional benefit. Immediate vitrectomy is of significant benefit to those who have only light perception vision. When the vision is hand motion or better, a vitreous tap and intravitreal antibiotic here has efficacious and recommended. So these are some pre and post picture. Treated only with intravitreal injection. Patient presented early, injection given, and end result was normal eye. No surgery has been performed in these cases, but in this case later on surgery required, but we can see that the infection is gone. So it is important for all to understand what will be the preparation of intravitreal injection according to the endophthalmitic vitrectomy study. Vancomycin and ceftazidime are the agents which are recommended. So this is how we prepare, and I think all information is available online. But 500 milligram vial, and withdraw entire content and saline, add saline to increase total volume of 10 ml. Place 1 ml above the solution and 5 ml syringe and add 4 ml of saline to total volume 5 ml. Resulting solution will be 10 milligram per ml and 1 milligram or 0.1 ml to be used. So these are the preparations of ceftazidime, preparation of gentamicin, amphotericin B. These are the most common agents what we use. Prior to the procedure, we need to reduce the intraocular pressure, and for that either we use mannitol, because if we want to use two agents, then we are going to increase almost 0.1 ml content. So either mannitol or paracentesis is to be done. This is a small video about the procedure. Two separate syringes are prepared. That's it for today.
Thank you, sir. Any question or any comment from anyone? It was very nice and crisp presentation, and just one query, like if you give intravitreal injections of antimicrobials, so do you tap for this, or with
Yes.
which needle will you use to tap, or would you like to use a cutter for that? What is your
Not always,
recommendation?
but if the severity is more, we definitely tap, and we use definitely vitreous cutter.
Okay, but in large majority, which needle will you use for?
30 gauge.
Okay,
Not for tapping. We don't tap with the needle.
Uh-huh.
If it is to be tapped, we remove that aspiration thing and then collect in the syringe. The cutter aspiration port is
Cutter
to be
aspiration.
replaced
So
by
through a trocar
one tube
and,
then you use the syringe
Okay.
when you use the cutting, so that it will not cause any traction on the peripheral retina.
Okay, so these days it has become easier because of the 27 gauge trocar, and you can use it and take out the sample easily.
So we use
sutureless.
trocar, connect the aspiration port with the syringe.
Yeah.
So directly we connect into that,
Yeah.
and then tell laboratory people to use the cytospin to do the cytology as well as culture both.
Okay.
Because cytology also will be helpful to know the things.
So how do you select case for that? Like where will you do it and where will you not take any sample?
I think if the cases are very mild, we see that the blanket therapy will work. But if the case is severe, then we don't have time to wait for blanket therapy. So in first instance, we have to send this sample to the laboratory. By the time if effect starts, next day again we will repeat the injection.
Okay.
If it has responded, but still if we think that the infection is still there, next day we inject again. And then even if it is not responding, then straightway we go to surgery.
I think intravitreal injections have become norms of managing not only infection cases, even for people for our retinal condition.
Anti-VEGF.
Anti-VEGF, so commonly used, and I have seen patients where intravitreal given aminoglycosides and entire macula is infarcted.
So vancomycin is a safer drug for that. If we use gentamicin or amikacin, they are dangerous drugs for cornea and macula both.
Any tips to know how to put the needle so that it doesn't go towards the
The needle will go perpendicular to the sclera, and you inject in the center of the globe. So that will help us to deliver the things, and if possible for injection, use 30 gauge needle, then 26 gauge.
Dr. Mehul, we get a lot of cases of trauma where we do anterior segment repair, sometimes corneal repair, corneal scleral repair. Do you recommend giving intravitreal?
All open globe injury during repairing intravitreal has to be a protocol.
Okay. What should be the common protocol for that? Which antibiotics?
Normally these two blanket, vancomycin, ceftazidime, but if we find some vegetative injury, then amphotericin B also can be added. Because open globe injury has got mixed type of organism, and we are not sure that which type of organisms are there to contaminate the wound. Because we have seen that if the cases are repaired fine on table, third day patient will present with the severe endophthalmitis if intravitreal injections were not given.
That's a very important point, especially open globe injuries. Some sort of prophylaxis has to be given to prevent.
I think both intravitreal as well as subconjunctival,
yes.
Both has to be.
Very good. I think he showed a nice video where entire conjunctival sac was put with the betadine. You wait for some time, let the betadine take action, then inject. And while withdrawing the needle also, they were putting pressure with the swastik soaked with the betadine.
So prior to injection, we have to make eye little softer. If we inject 2 injections, the pressure will become higher, and already painful condition, it will cause more pain. So either we do the paracentesis or we use the mannitol.
Thank you, sir.
Thank you.
Thank you, Dr. Mehul.